These are in listen-only mode.
Well, welcome and hello to all of you who are joining us today for the February edition of the NOFAS, National Organization on Fetal Alcohol Syndrome webinar series. I'm Tom Donaldson at NOFAS in Washington, D.C. Thank you for joining us. This is the third year for the NOFAS webinar series where we have been bringing you the top experts on just a wide range of topics associated with fetal alcohol spectrum disorders. And today it gets even better with our presenter, Dr. Jackie Bertrand, and also the topic, proven and promising interventions for children with fetal alcohol spectrum disorders, a topic that so many of our viewers have expressed an interest in hearing more and more about. Before we begin, I'll just two quick reminders. So during the presentation, if you have a question, you can see on the right side of your screen the panel, the go-to webinar panel. There's a place where you can type in a quick question. Don't hesitate to do so at any time during the presentation, and here at NOFAS we'll gather those questions. And if we have time near the end of the hour, we will ask Dr. Bertrand to address a few of those. If we don't get to those, then NOFAS will work to respond to you after today's live broadcast. Also, after the broadcast, you will be able to access the complete presentation in archives from nofas.org. That'll be available in about 24 hours by about this time tomorrow for download. So if you missed anything or you want to go back and take a look at some slides again, you can do so. So we're very excited to have Dr. Bertrand with us today. She's a licensed psychologist, and since 1996, about as long as I've been here at NOFAS, she's been a behavioral scientist working on developmental disabilities and fetal alcohol spectrum disorders prevention programs at the Centers for Disease Control and Prevention, CDC. She has worked extensively on the research into the neurodevelopment of children, including children with prenatal exposure to alcohol, published many articles, and I know presents very often. And Jackie, we're delighted to have you with us today, so welcome. I muted her. You have to unmute her. Oh, Jackie, sorry to jump in. You may be muted. Please check your settings.
Tom, can you hear me now?
Yes, we can.
Oh, why? Oh, you can. Oh, good. Thank you. I apologize for that. Thank you, Tom, for that nice introduction, and thank you very much to NOFAS for hosting this webinar on this very important topic about interventions for children and also older individuals and their families who are affected by fetal alcohol spectrum disorders. We here at CDC think this is a very important topic because although primary prevention and preventing these disorders is all of our top priority, we know that children and adults and their families are still affected by these disorders, and interventions are some of the best ways to avoid some very negative lifelong consequences that we all know about, like school failure or work failure, substance abuse problems, mental health problems, or even involvement in the law. So this is a very important, continues to be a very important topic. And I'd like to point out that when we here at CDC first became involved in this issue in 1997, around 1997, there was actually no research onto interventions specifically targeting these individuals. Most of it was word of mouth, clinical wisdom. The internet really wasn't up and going then, so you couldn't even get stuff off of there. It was really a bleak landscape as far as interventions, but there has been a real takeoff over the years, and so I'm very pleased to be able to have been involved in some of the research developing and refining these interventions and to bring them here to you today. My one caveat is this is a presentation I haven't given in approximately 5 years, so I apologize if I leave out any important bits, and we can cover anything I missed during the question period. So, Tom, why is my... There we go. Okay. Who I'm going to be talking about today is children who have a fetal alcohol spectrum disorder and have behavioral implications with their diagnosis. So fetal alcohol syndrome, partial fetal alcohol syndrome, and what's now called neurobehavioral disorder associated with prenatal alcohol exposure out of the DSM-5, formerly known as AR&D. What I will not be talking about is children who have ARBD, alcohol-related birth defects, and need medical interventions. I'm not going to be talking about medications or supplements such as multivitamins or choline or things like that, or other medical treatments. These are really behavioral interventions that I'm going to describe. And I'm kind of going to go through at a fairly quick clip, and if we finish early, that leaves more time for questions or other, I know we're all very busy in other activities. So I want to start okay. As an overview, I'm going to first talk about what are very basic interventions and interventions we knew that are special education, off the shelf, ready-made. They're available for any child with a developmental disability. They basically work. But we need a full shelf of very specific interventions that target the strengths and weaknesses of children with fetal alcohol spectrum disorders. I'm then going to go through 4 interventions that we funded the research and development of here at CDC, and it's because I know those the best. I was the project officer for them, and they're really the ones that have the largest evidence research base to them. They've gone through randomized control trials, translation research out into the community and things like that. Then I'm going to touch quickly on interventions that are in the pipeline. They don't have the full evidence research base, but they're out there. They've got some good evidence behind them, some good work behind them, but you know they're on their way. They're working their way through the pipeline kinds of things. And then finally, I have a final slide to wrap up like everyone always does. So, okay. Okay. These are the 4 intervention research, evidence-based interventions that we funded at CDC. That's why you see us in the middle. These are the 4 I'm going to talk about. The Marcus Institute did a Learning Readiness in Math program. University of California, UCLA, did a Friendship and Peer Relationship program. University of Washington had a program that was a little more therapy-based and looked at children who had clinically significant behaviors. These are the children with very challenging behaviors, and Heather Carmichael Olson, who was the PI, she herself describes them as the most challenging kids, the worst of the worst. They really had a lot of externalizing problems. And then finally, Children's Research Triangle, which did some nice work with executive functioning. I know a topic that is on everybody's mind. So those are what I'm going to talk about. So this is the basic randomized control trial that all 4 of those interventions I just talked about went through. And we developed this overall paradigm by, we had a couple of, before we started the research and those activities, we had a couple of meetings that had subject matter experts, a lot of clinicians, a lot of educators, people who had been working on the field, in the field, and had been hands-on working with children who had fetal alcohol spectrum disorders. And so we gleaned from their clinical wisdom, from their expertise in their fields, and we decided there had to be some basic components that we knew had to be in the intervention and all children needed to receive. First of all children had to go through a comprehensive medical, psychological, and environmental assessment upon entry into the research and into the study. And the reason for this was that FASDs is a very heterogeneous group of disabilities. Because you're working with an what you see in the child is a very complex interaction between how much alcohol they were exposed to, when in gestation they were exposed to the alcohol, what was the pattern, was it chronic drinking, was it binge drinking, and every child has their own genotype, and then you have what environment is that child growing up in. It creates a very heterogeneous group of children with disabilities, and much more than other diagnoses. This is a very varied group of children. So you needed to know what all the facets are that you're working with in any particular child. So that was considered very important. Also, parent education was considered very important, and that was very recognized early on, that children with FASDs have prenatal brain damage, and parents need to do their parenting and do their advocacy for their child looking at it from that perspective of being brain damage, and that not the child being willfully not cooperating or willfully not learning things. But so it really became that parents needed to shift their focus and shift their way of thinking about things, and teaching them how to do that or educating them about how to do that was considered important. Finally, linked back to the comprehensive assessments, there had to be each program had to have a set of referrals in place, a menu of items beyond the targeted intervention that children could be referred to. So if a child needed to get into special education and needed help from the research program to do that, it was best to help them with that before you tackle the target intervention, if they needed help with getting SSI or something like that. So if you need to have these other things in place as well as your targeted intervention to make sure you don't overwhelm the intervention, and that your intervention doesn't fail because other things are going on. So getting all those other things in place. So kids in all of the programs were then randomized. They all got those three components, and then they were randomized into either the target intervention or the standard of care, which was pretty much the comprehensive referrals. There wasn't much beyond that. So that's the basic research design. And what I'm going to do now is start with the California group, which was finally named Good Buddies. Some of you may have read it before as Bruin Buddies or Best Buddies, but those names were trademarked. So finally they settled upon the name of Good Buddies, and it's really quite a lovely intervention that is highly regarded by parents who have participated in it. I've actually interviewed parents, and they just really find it lovely. What the intervention is a 12-week group session for both children and parents. It's focused around getting children to improve their social skills and their peer interaction skills. It builds some very solid, concrete social skills. And what they do is they have 12 weeks of group sessions. Child and parents come in together. They kind of get a little overview of what's going to go on. And then the children separate into a group by themselves, and parents stay in their group by themselves. And this is the parent education component I just talked about. But they get not only an overview of FASDs, FAS 101, but they also each week take a particular topic and discuss it and talk about it with a defined curriculum among parents. And children go off, and in their group they not only discuss the topic, but they do some real-world practice of each of these skills. And some of the skills they work on are mostly basically the things that most children learn through osmosis on the playground: how to slip into a group, how to not dominate a conversation, how not to be overly aggressive, and things like that. Now, most children learn this through osmosis on the playground, as I said. Children with FASDs have trouble learning from their own experience. So they're not learning it through osmosis, and they need this kind of explicit instruction. And so they're learning things like how to slip into the group, how to deal with teasing or what's now being called bullying. And I have some examples of that in a minute. But over the 12 weeks, most of what they do is build up a play date. So you break down what it takes to make a play date into all the little different components. You need to figure out who you're going to invite to your play date. So they spend one whole session about talking about who is a good match for you on a play date. Then you have to think about what you're going to do on your play date. So they spend another session talking about and figuring out, well, you can't just do what you want to do. You have to do what your guest is going to want to do also. And how do you think about that? And how do you figure that out? And then they actually practice making the phone call of how you would invite somebody to a play date, what you would need to put in place for a play date, and they go all the way through and over the 12 sessions. So that's the overriding framework that guides the 12 weeks, in addition to these other more specific topics like teasing. And as far as teasing, one of the really nice things that this program does is it not only explains the concept of when you're confronted with somebody who's teasing you, you want to have a response, but one that says that your response really should say, what you're saying doesn't get to me, I'm not going to bite at the bait, that kind of thing. But for children with FASDs, you can understand that concept, but the demands in the live situation on the playground or in the school lunchroom is really kind of overwhelming, and so those demand characteristics. So what they do is actually teach very explicit, in-your-pocket kind of responses, so the child doesn't have to think through their response, but they already have some things in mind. Things like, talk to the hand because the face isn't listening, or saying, and your point was, and they really do the exaggerated, they kind of practice it. They literally explicitly practice these kinds of things. So that's the kind of, that's an overview of that intervention, and you can see over here on the right that, oops, so sorry, that from baseline to after intervention, there's an improvement in social skills, a rating scale that's done by both teachers and parents, whereas the control group you don't see as much change. And I just have my little webinar is over on the right, so I can't see the right hand of my slides very well, so I can't explain that very well. So that's Good Buddies. It's very effective. It has been published. They have also published that this can be used in a broader settings than just university settings. It also holds and generalizes to time in children actually retain these skills. They start generalizing them beyond just the playground or the school into any new situations they have. Parents also learn the techniques and start generalizing and applying and helping their children apply them to new situations. Okay. The next intervention is MILE, which stands for Math Interactive Learning Experiences, and this is out of Emory University here in Atlanta. So yes, I know them very well, Julie Cable and Ella Tato and Claire Coles. And this is much more of an academic intervention and really intended to be implemented in schools or after-school programs or tutoring programs. It's based on the key math curriculum, which teaches children and reinforces and really gets them to habituate and routinely do planning what they're going to work on, do what they're working on, and then review how how it works. It's done in one-on-one tutoring sessions. There's also a parent education group. So you can see here one of the really fun parts of this intervention is that it uses lots of manipulatives. It's very multimodal. So there are lots of things about counting and lots of different kinds of things to count so that you get the texture and the situation of counting, say, little poker chips or counting little fluff balls. So it's not only just the idea of counting or the verbal stimulation, you also get that physical stimulation of counting and that math skill kinds of thing. There are also all of these supportive things that you can use. So here you set well, let me start on the far right. Most of us remember in first or second grade, along the front of our desk, we had horizontally a number line, and to the left was the lower numbers, to the right was the higher numbers. Well, that's not very intuitive, actually, and for a child who has difficulty in coding or their speed of processing is kind of slowed down, if you can't build on the intuitive, it makes just the math concept that much more difficult. If you take that number line and turn it 90 degrees and make it vertical, it's much more intuitive, and kids with FASD really get the concept and then can start using their numbers up and down and learning the concepts of greater than and less than. It just makes sense to them. So this is the vertical number line, and that accommodation works very well. The other one here is the grid for writing your numbers. I think we all remember the kid in first grade whose math problems sort of slid off the page and their numbering just slid off the page and they couldn't get things to line up. Well, that makes learning the concept of ones, tens, hundreds, thousands, that kind of makes it very, very difficult. And then when you move on to the next thing, such as addition, subtraction, multiplication, and division, you're just totally lost if you haven't got the original concept of lining things up, tens, ones, hundreds, and things like that. A way to fix that is having children do their math problems and writing numbers within this grid. And actually, you can buy this grid paper. They're actually quarter-inch squares. They're quite large, so they're very good for kindergarten, first, second graders kinds of things. And you can buy that. So using all of these props and using this one-on-one plan, do, review kind of program, we see that children in the math group, their math skills and their math knowledge got a lot significantly better, statistically significantly better. Kids who did not didn't see as much of a difference kind of thing. So the difference between the math and the no math curriculum was significant, and this intervention really does a lot. Now, I have the CBCL up here. These are maladaptive behaviors, and what the interesting thing is that even though this is an academic intervention, you saw improvement in children's behavior. And as an aside, the previous one I just talked about, Good Buddies, even though that was a social intervention, they did note some improvement in children's academics. So there's some generalization and spreading out. Okay, I'm taking a little detour here. That vertical number line I talked about and the grid. The grid paper you can buy at any school box or school supply store. The vertical number line is available at this do2learn.com website. It's run by Dorothy Strickland. So she has, it's do2learn, and she has a whole bunch of information about different disabilities, including fetal alcohol spectrum disorders. And she actually gets it correct. This is information off the internet that you can trust, and she gets it right. But you can also find on her website here's the number grid if you want to print that out, and here's the vertical number line. I've never seen the vertical number line at a school supply store. So this is a good place to get it. All right. The next intervention is the Parents and Children Together PAC intervention. This is out of Children's Research Triangle in Chicago. And this is an adaptation of the ALERT program, which was originally for children with ADHD. And it focuses on executive functioning and recognition of a child's behavioral, physical, emotional state, and then giving them strategies for managing each one of those states. So think about being revved up, anxious, tired, hungry. Children with fetal alcohol spectrum disorders very often don't recognize the signs. They don't learn from their own experience of, oh, this is what it means to be tired, or this is what it means to be hungry, like most children do over the preschool and early school age years. So this does it very explicitly again. Again, they have 12 weekly group sessions. Again, the parents and children come in, and then they split up into their separate groups where they get their own either parent education or kids get their curriculum and then practice kinds of session. There's also some case management going in, and like I said, the parent group. For this intervention, using the brief, which is a parent measure of the child's executive functioning, saw improvement in there. We also saw a decrease in conduct problems and disorders for kids in there. So here are some of the props that are used for doing the PAC program. You see there right up in the front in the middle is the it's called How Does Your Engine Run? And so it's getting kids to learn what does it mean when they're revved up, when they're hyper, they're overactive, and getting them to pay attention. Am I hyper? Or at the opposite end, am I sluggish? Am I tired? Am I running down because I need to have a little protein snack or something like that? And then you get the green portion right in the middle, which is where you want kids to be for good behavior control, doing academic lessons and things like that. So they use this as a visual for kids to learn, and they practice feeling how they're feeling and then labeling that. On the left is the body, and so different states, where do you feel hungry? You feel hunger right in your tummy, but where do you feel anxiety? You tend to feel it over your shoulders up into your neck. Where do you feel anxious? Very often you feel like moving, and so your hands or your legs want to move, kinds of things like that. So that's just a visual prop, an aid to help kids. And then there are two other little games that I know less about, pictured on the right there, kinds of things. But these can all be handmade, or you can work with Children's Research Triangle to obtain them and how to get them done. All right. And finally, the fourth one is Families Moving Forward, which is done by Heather Carmichael Olson. She was the PI out at University of Washington, Seattle Children's Hospital. This is a little different than the other programs. This one works and targets caregivers, parents. This is really aimed towards parents rather than working directly with the child. And it's all about getting parents to recognize their needs, what they need to be doing for themselves, what they need to be doing advocacy-wise for their children, either with the school, with developmental services. And so what they have is a large number of worksheets, and it's a one-on-one program where a therapist comes to the parent house and works with them on a weekly or biweekly kind of basis, and they actually plan out it's very individualistic. So what does this family need to be working on? What does this parent or caregiver need to be working on? And so all of their materials are on the web, available to therapists who have been trained in the Families Moving Forward program. And they print out every week what they need to be working on, and they progress through. what that individual family needs to be doing, and helping them strategize how to do it, and really building a lot of caregiver effectiveness and empowerment. And what we see is that even though this is a intervention that's geared towards the caregiver and the parent, we see positive change in children. And so we, first of all, we see self-care kinds of things go up for the individuals in the intervention, the families in the intervention, versus families who are in the comparison or control group. They see more family needs being met, again, in the intervention group, not so much in the comparison or control group, but we see positive behavior change as measured by the IBERG child behavior inventory. So again, even though it's targeting caregivers, that translates down to kids, which is a good thing. So across these interventions, what did we see? We saw that explicit teaching techniques are best for this population. So giving out-of-pocket or in your back pocket kinds of answers to teases is good. Being very explicit about teaching bodily sensations and how you can, and then specific actions you can take about them. If you're hungry, you need a protein stack. If you're revved up, you need to retreat to a quiet space, but not expecting children to learn that by experience and learn it on their own, so to speak, but giving them explicitly what they should do. We also saw an unanticipated benefits, so academic interventions yield behavioral benefits, behavioral social interventions yield academic benefits. And as we knew going in, there is a great value to parent education and starting to think of children with FASD as having brain damage, and what they're doing, it's not a can't, it's not a won't, it's a can't because of the brain damage. And shifting that perspective really had a lot of value for parents, and in all the interventions, the feedback we got from parents was that that was very valuable. Okay, so those four were all done in very pristine, lovely university settings, which is great and wonderful. However, most families and most individuals live out in the community. So we did a phase 2 where we had each of the interventions partner with and adapt their interventions to community facilities, community programs. And you see those off on the left. There's after-school programs. There's a mental health facility. There's a rural Midwest primary care setting, and a developmental disability. And across, what people learned is, though academics love big fat manuals, if you're out in the community, no, your manuals need to be revised and shrunk down. They're still pretty big, but they all realized they had to streamline all of their materials and all of their manuals. They had to contend with a lot of personnel training, so they couldn't just go in once and train staff to do these interventions because there's frequent turnover, and they needed to adapt and make sure the interventions could handle that. They realized that most community situations, they're dealing with children with multiple disabilities, children with a wide range of disabilities, developmental disabilities, and so they had to integrate these interventions into those programs for the kids with FASDs, but keep the fidelity of what aspects were specific to FASDs. Overwhelming paper reduction, and they also had to adapt to facilities. They're not always in a nice little lab situation with a quiet room. They had to make sure that the interventions were robust enough that they could deal with children, right next door in the gym playing basketball, or right outside in the hallway, and those kinds of things. One of the adaptations that nobody had to make not a single family dropped out of this, which speaks to the need for these interventions and how effective they are for these children and these families. So that was phase 2. And this is just all of these interventions. There's one overview paper that you see right up there in Research in Developmental Disabilities from, I'm going to say 2009. I can't even remember when I wrote it. But anyways, there's continued to be a series of research papers out about different aspects, whether it's the longevity of these interventions so that, children don't lose those skills right after they leave, or some of the transition kinds of things, or some of the other newer adaptations. So this is a set of interventions that is developing a very large and strong research base, which is why we consider them evidence-based. So, and we worked over the past couple of years with NOFAS to develop a brochure on these interventions that could be used in professional organizations. For example, the American Academy of Pediatrics meeting that happens every year. It is not only, it describes each one of these 4, it also provides some information on diagnostic categories and some information on NOFAS. And one of the reasons we thought this was important was because early on in the late 90s when we started this, one of the feedback we got from a lot of pediatricians was, well, I'm not going to diagnose this because there's nothing you can do about it. As the number of research papers I just showed you and the effectiveness of all of these, we've gotten rid of that myth. And this brochure is available through the NOFAS website, and we hope it goes widely and helps disseminate all of these. So what I'm going to do now is talk about some research that, or some programs that are in the pipeline. They generally do not have randomized control trials, but they are still shown to be efficacious for children. So you see they may not have a control group, but if you give them, provide them to children with FASDs, you do see improvement in whatever targeted skill. So they're in the pipeline and the research base is building. Okay. First, this is one that was funded by CDC, and after we did the first 4, we got a lot of feedback from parents and families at a lot of meetings that we needed something not only for school-age children, but for youth and young adults. So we funded 2 programs. This is one of them, Partners for Success, originally out of St. Louis University, now out of University of Missouri, Columbia, Lee Techno, you see her name down here. And this is modeled after the Families Moving Forward, the low-level, over time kind of intervention, and it involves therapy, in-home therapy for the family, but it, much like the Families Moving Forward, but then also does a specific one-on-one mentorship for young adults. And then there's an online support group that also goes with it, but that's available pretty much to anybody, kind of thing. And what they targeted was decreasing maladaptive behaviors while increasing adaptive behaviors, improving self-esteem, and really staying in school or work and making sure to head off that kind of negative event. So over this, what the findings were, very positive. They had, participants had, with FASDs had fewer negative events. Their maladaptive behaviors went down. They had better self-control. They were more likely to take responsibility for their actions and actually own up and fess up to things. They were able to learn that, if they were honest and took responsibility, unlikely to be very negative repercussions. They had improved academics and better coping. The families reported a significant decrease in parental stress and a significant increase in feeling empowered and going out and looking for appropriate services for their child or actually young adult. A second project that we funded under the same FOA was Project Stepa. This is out of UCLA and Mary O'Connor, and it was specifically geared toward reducing or preventing alcohol consumption among 13 to 18-year-olds, really trying to get at heading off substance abuse or alcohol misuse and abuse kinds of things. They wanted to reduce negative consequences from alcohol consumption, such as injury and those kinds of things. And they wanted to improve caregivers' ability to talk and monitor their youth or young adult for alcohol use and misuse. The intervention was for 13 to 18-year-olds. It was 6 weekly sessions that lasted an hour. It was back and forth, role modeling. It was your pretty basic group therapy session, although each of the persons that ran the group was specifically trained in dealing with the executive functioning, impulse control problems that go with individuals who have FASDs. There was also caregiver sessions. Okay. What they found was at the end of the program, participants reported having fewer drinks over the past month or the last weekend, less binge drinking, high-risk drinking, and fewer negative consequences. This is a research paper that is being submitted and should be out in the literature fairly shortly. Now, Project Step Up and Partners for Success, they both had one problem. And the problem was keeping adolescents and youth engaged in an intervention or a therapy situation was quite difficult. So they did have fairly high dropout rates and no-show rates and things like that. But that's a problem that's fairly common across all adolescent interventions and research kinds of things. Probably, you know, a widely known youth and adolescent issue. Okay. All right. This is a fire and safety computer games that have been developed by the group Claire Coles, Julie Cable, Lynn Paget over at Emory. And this teaches children like 5, 10-year-old range about fire and street safety through computer games. And what children do is they play the game where the character here, Buddy, the little puppy, has to go through a virtual home. So in fire safety, the child is getting Buddy to navigate through the home, 6 rooms, and there's a meeting place outside, and he has to know what to do when he encounters a fire. And these are the 4 components that they want children to learn: move away from the fire, leave the house, go to the meeting place, and wait. And very similarly, there's Buddy here learning to cross the street safely, where you have to learn to hold an adult hand, look both ways, and check for cars and stay on the crosswalk. So the child navigates through these 2 scenarios and learns what Buddy is doing correctly, and they get rewarded every time they have Buddy do the correct thing. If Buddy doesn't do the correct thing, the screen goes blank, and they start the game again. There are a couple of things like the child is never allowed to do. So the child has to look both ways before crossing the street. They're never allowed not to do that, and the program just won't go forward. And so this research compared these 2, and children, whether they got fire or street safety, they improved skills in that area, that type of safety. But a little later on, they were able to document that children who got fire safety also could generalize to street safety, and children who got street safety were able to generalize to fire. One of the nice things about this is it's very multimodal. So children are seeing buddy, they're hearing sounds, and they're using their fingers to navigate through. Okay. Again, from the Emory group, this is something they've been working on called GoFar, another computer-based program. And this one targets metacognition or executive functioning, and it's teaching children to go far, focus, act, and reflect. I'm sorry. Focus, act, and reflect is the far part. And the child goes through a series of 5 puzzles, 5 levels of puzzles, and they have to overcome little obstacles. And to overcome those obstacles, such as finding a key to unlock a door, they have to think it through, and they have to do a plan of where they're going to find the key, where they're going to look for the key, and how to do that. And that allows them to be successful. Now, many video games out there, a child can get engaged in them, but you can learn them by trial and error. One of the nice things about this program is that trial and error won't work. You actually have to go through the focus, act, and reflect set of steps to learn them. So the child could learn, in this research, they could learn it through this computer game. They also had a more didactic therapy in this study. So the focus, act, and reflect could be taught either through the computer or through a didactic therapy kind of situation. So we're almost there. So the next one, this is a curriculum called Triumph from Double Arc in Ohio, and I believe Sister Suzette Fisher gave a NOFAS webinar last month on this, so I won't go into it a lot. But this is really a educational and awareness program for parents, educators, other facilitators, and they run it kind of like a couple of day retreats, and they teach all about FAS and what the characteristics are, what the strengths and weaknesses are, and then provide some very concrete suggestions for classroom modifications or home modifications, the picture timeline, picture schedule kinds of things. So I'm not going to go too much into that, but it's very nice and it's available at their website. Okay, and finally, this is a intervention that really would be classified as a case study. This is Alal and his service dog, Chancer. You see in the middle, Chancer, the golden retriever, is wearing his service dog vest, and he was trained specifically for Alal, who has FAS, and mainly to help Alal deal with overwhelming situations. So when Alal, this is a staged picture, but when Alal was about to have a meltdown, Chancer could detect that. He was very attuned to what Alal's state, emotional and behavioral state was, and so he would get Alal to sit down, and he would lie across his lap so he wouldn't flail, but just the pressure, the warmth, the calmness of Chancer would help back down that tantrum or that meltdown. Also, this is over here on the left. It's not just sleeping with your best friend or your furry best friend here, but Alal had a lot of trouble falling asleep. And so Chancer, again with the weight and the pressure, but also his very rhythmic breathing, was very soothing to Alal and helped him sleep. So that was another part of the intervention and the therapy. I mentioned this family, the Winokur family, Alal Winokur, also because they have a couple of books that they've available through their website and Amazon. one about Chancer and showing how he is a wonderful service dog, but also one written by Alal's sister, Marasha, who's also adopted from Russia, and her perspective on having a brother with an FASD, and which I find just that sharing can be a very helpful intervention for siblings of children with FASDs, and really starting to think about interventions not just as the child, but as we know, family, parent and caregiver education and awareness and tactics also help. We need to broaden that, and hopefully more about siblings, some of that research will come along the way. So, in summary, across interventions, things that we know are that interventions are beneficial to individuals with FASDs, children, youth, young adults, whole families. Specific interventions are best, but even the basic what's available in the community can help and reduce some really devastating lifelong negative consequence. And research is growing, and more interventions are available. I certainly did not cover the whole waterfront, as I said in the beginning. These are interventions that I know and have the most experience with, but I hope they're helpful, and people can access them and spread them. Here we go. For more information from CDC, you can always go to our website, cdc.gov/FASD, or we have an 800 number, CDC info, if you have a specific question. And these are just some of the materials, most about primary prevention, but some other information about affected individuals is also in that website. And finally, I would like to once again thank NOFAS for doing this webinar. And if anybody has any questions, I'll be happy to do what I can to answer them. Tom?
Well, Jackie, that's just terrific and invaluable information. Thank you so much. I've certainly learned a lot, especially on the interventions other than the ones that, as you referenced, NOFAS had a chance to develop the brochure working with CDC on. And let's see if we can get to a few questions here before the top of the hour. Before I do, many people, of course, are asking, how do I get in touch with these folks and learn more? And as I mentioned at the outset, by tomorrow at this time, we will have today's presentation archived. You can download that and just quickly advance through it as you'd like. And as you've seen in Dr. Bertram's presentation, she had contact information on many of the slides for each of the interventions. So if you can be patient just for 24 hours, everyone, in fact, who registered for the webinar will get an email with the link to the archived version. So certainly look for that. You can also contact me and contact NOFAS, and we'll get information out to you. The brochure, I should mention, it's available online at CDC's website and at NOFAS, and also copies here from NOFAS. Beyond just having the information for yourself, I know that many of you have practices or have occasion to be with folks who may have a loved one who's affected by FAS, FASD, and so you can get quantities of the brochure from NOFAS. They're free. Just have to drop us a note, and we'll be happy to immediately get those out to you. So, Jackie, here, I wish we had another hour, but there's really some terrific questions. Maybe I'll try to get a couple in quickly. And first, a couple of people sort of pointed this out and were struck by this, I think, in listening to you. And one specific question says that it makes sense, but they didn't realize that such a big part of intervening has to do with educating or training the parent and the caregiver. So just how critical is the parent and caregiver's role for successfully improving outcomes? Jackie, are you still with us?
I'm sorry. I'm just getting used to my new technology here. I apologize. I think it's essential because if you think about it, you can do all the intervention you want at school, and you can send your child off to school and do all kinds of great intervention, but it can absolutely be totally undone as soon as they step into the minivan or get home or things like that. If you're thinking things like, oh, you're just being defiant because you won't do something, rather than understanding that, no, part of this disability is you learn skills, you master some skills such as tying your shoe or finding your locker, and then you lose that skill and it has to go, you have to be taught right over again. So I actually think it's really critical for changing the mindset of how you interact with your child, also realizing that there are accommodations usually in the home that are helpful, and actually it's very helpful for parents in reducing their stress if you have a picture schedule, if you have a set routine, if you understand that shifting attention is a big problem. So when you're going to transition in the morning, you have to have a very set routine and a lot of warnings that go with, we're going to be leaving in 10 minutes, we're going to be leaving in 7 minutes, we're going to be leaving in 4 minutes. It just reduces the stress and doesn't undo the other types of intervention. I think it's very critical, and it also really empowers families to understand what they're advocating for, specifically for their child when working with school systems or developmental disability systems, and it also relieves a great deal of stress, which helps any family.
Okay, a couple more here. Have you found that the interventions, in addition to the findings that you did report on, but have you found that they indirectly also reduce sort of some of the hallmark secondary disabilities, such as the disrupted school experience, trouble with the law, inappropriate behaviors?
For the major four I talked about, the kids were not old enough to really measure that. That would be a very interesting study to turn around and go back to those families and see how they're doing now that those kids are 5 to 10 years older, and see where they're at. I suspect they are doing better. And it is that these interventions are helpful in getting them prepared and getting the family prepared to launch their child into adulthood. What we know from the 2 youth and adolescence studies is for those you could retain in the intervention, yes, you were able to reduce some of those adverse lifelong consequences and secondary conditions.
We have a few more questions that, Jackie, I'll send you an email and ask if maybe you or your team might be able to address them, after we sign off today. But maybe if we could leave with just a getaway question, something that NOFAS here knows full well, but I wonder if you would sort of share, maybe beyond some of the interventions you described, other things that the CDC is doing on this issue. I know well for 20, 25 years has been a leader here in the United States and beyond in just a range of programs and projects, materials that have been developed on fetal alcohol spectrum disorders and fetal alcohol syndrome. Could you say a few words about other things that you all are working on?
Oh, my pleasure, actually. In 2014, well, our big project, which almost all of our team is now involved in and wrapped up in, is in 2014 we funded 6 practice implementation centers to actually go beyond just training or demonstration sites, but actually working with professional organizations such as the American Academy of Pediatrics or the American College of Obstetricians and Gynecologists to change practice around prevention issues, actually getting primary prevention to be the routine standard of care, asking women, screening women for their alcohol use, and advising them about the harms of alcohol use, especially during pregnancy. 2 of our practice implementation centers are working specifically with the American Academy of Pediatrics. That's the University of California at San Diego and the University of Wisconsin at Madison. and they are working on issues of getting children actually recognized and properly diagnosed. There's what we know from some surveillance that we have done, and also some NIH-sponsored surveillance, is that FASDs are a very under-recognized disorder, and so we're working with professional organizations to improve the skills of practicing clinicians to recognize, to make sure that they screen moms and children coming into their practice for prenatal exposures, especially alcohol, and just improving that rate of recognition and diagnosis, as well as improving primary prevention around screening and brief intervention. So that's our big project right now, and we're very pleased, and we think it's going to be very productive.
Well, it's very exciting indeed. Well, Jackie, you're terrific. You're wonderful. NOFAS and I can't thank you enough for doing this. Just remind all the listeners again that you can take a look at this shortly, by tomorrow, and get all the information you need. Those of you who had some questions just here in the last 4 or 5 minutes, we will do our best to ask Jackie and her team to help follow up with you, to help respond.
Absolutely, and, that's easy for me to do, and I look forward to it.
Terrific. Thank you very much, and thank you all for joining us, and look for us again next month for the next edition of the NOFAS webinar series. Thank you, everyone.
Thank you.